Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides commentary on the JCO article, Assessment of BCR-ABL1 transcript levels at 3 months is the only requirement for predicting outcome for patients with chronic myeloid leukemia treated with tyrosine kinase inhibitors by David Marin et al. My name is Dr. Richard Stone, and I am the director of the Adult Leukemia Program at the Dana-Farber Cancer Institute in Boston, Massachusetts, United States of America. My oncologic specialty is treatment of leukemia in adults. The title of my podcast is Using BCR-ABL transcript levels after 3 months of therapy on Imatinib is the best way to predict long-term outcome for patients with CML treated with Imatinib. The use of tyrosine kinase inhibitors has made a high impact on the natural history of patients with chronic myeloid leukemia, or CML. When an agent such as Imatinib is begun in CML patients in chronic phase, most can expect to enjoy many years of leukemia-free life, with perhaps a proportion being cured with this medical therapy alone. However, approximately 1/3 of patients need to discontinue Imatinib due to side effects or disease progression. It would be ideal to be able to identify such patients as early as possible in their disease course so that alternative therapies could be used, especially if such therapies led to a better outcome. Since the initial use of Imatinib in the early part of the first decade of the 21st century, there has been much interest in the identification of patients who will not do well with long-term Imatinib therapy. The European Leukemia Net has composed a widely used series of milestones which patients should achieve in order to be considered good responders. These milestones have been frequently taught as gospel to trainees and practitioners. For example, for an optimal response, patients should have at least a cytogenetic response at 6 months, complete chromosomal response at 12 months, and a major molecular response, reduction in transcript level by 3 logs by 18 months. Not only do questions arise whether these landmarks are the best, but they require serial bone marrow examinations. However, if the measurement of BCR-ABL transcript levels is a faithful way to determine the level of the tumor, and if the level of the tumor correlates with long-term outcome, then perhaps merely an early assessment of the BCR-ABL transcript level will suffice to predict response. Such was the reasoning employed by Marin et al. In their potentially groundbreaking study that suggests that measuring the BCR-ABL transcript level at 3 months is the only test required to optimally predict long-term outcome. The notion that an early assessment of tumor response would be an optimal way to predict long-term outcome is not new in oncology. It is recognized that achieving a rapid response is correlated with outcome in diseases as diverse as leukemia, with a rapid reduction in peripheral blasts, lymphoma, with a response to R-CHOP within the first 3 cycles, and breast cancer with a response to upfront or neoadjuvant therapy. Because serial measurements of BCR-ABL transcript levels are frequently performed, and in this case at Imperial College London they were measured at least every 3 months, one can compare the predictive value of measurements at certain time points and compare this with the predictive value of more traditional milestone measurements. The stunning findings in the paper by Marin et al. Are that the first measurement of transcript levels at 3, 6, and 12 months are highly predictive for important clinical outcomes, including survival and maintenance of complete cytogenetic response. The investigators established cutoffs for transcript levels, which would put a patient at high or low risk of event-free survival or complete cytogenetic response. Also, such transcript levels could be used to predict complete molecular response at the 8-year follow-up point. While the ability to achieve a major cytogenetic response at 6 months or complete cytogenetic response at 12 months were predictive of outcome, the transcript levels at 3, 6, and 12 months were more predictive when the proper cutoffs were used. Moreover, if one compared the time points of different transcript levels, the 3-month transcript level was the most predictive. Those who were above the cutoff at 3 months were less likely to achieve any of the positive milestones and not likely to achieve a complete molecular response. The implications of this data, confirmed in a different data set from another teaching hospital in London, are profound. First, if reproducible, one might be able to obviate the need for bone marrow examinations and frequent monitoring. Those who fail to achieve an adequate degree of cytoreduction at 3 months could be allocated to alternative therapies. Most of the patients who had high transcript levels early on were switched to a second-generational tyrosine kinase inhibitor, yet they still do not respond well in the long term. Thus, the ability of the second-generational TKIs, potent BCR-ABL inhibitors, to improve a lot of such patients is in question. Several caveats emerge from this initial conclusion. If patients cannot be rescued with utilization of a second-generational tyrosine kinase inhibitor once they do poorly, would initiation of such potent agents at diagnosis change the results of the analysis conducted in this paper? This scenario is possible given the outcome of the trials which compare the use of imatinib, nilotinib, or dasatinib to imatinib in untreated patients. In each case, there was a more rapid, at least at the 1-year mark, achievement of a major molecular response. Whether the use of nilotinib in the upfront setting would necessitate a different cutoff for BCR-ABL transcript level or indeed a completely different conclusion due to their increased potency remains to be determined. At least the data by Marin et al. Call into question the strategy of using imatinib in all patients initially, followed by a second-generational TKI only if needed. This approach has particular interest in an era where imatinib will be going off patent. Another interesting question posed by the data in the optimal monitoring strategy is the optimal monitoring strategy in patients who do have an adequate level of transcript reduction at 3 months. Most but not all of these patients are destined to do well. A novel monitoring strategy is needed to capture this relatively small group of rapidly responding patients, which makes up about 15% who will still have a problem. Even using a higher cutoff, most patients fall into the good risk category, but about 9% fail to maintain their complete cytogenetic response. If we eliminated follow-up monitoring after 3 months, how would such patients be detected? The authors call for early clinical intervention in patients who are identified to fare poorly based on a high level of BCR-ABL transcript at 3 months. What should the nature of this early clinical intervention be? Should we resort to stem cell transplantation, or should we consider alternative tyrosine kinase inhibitor therapy, such as ponatinib, which is currently being developed because it can inhibit the T315I mutation, often seen in patients with secondary tyrosine kinase inhibitor resistance? The available data suggest that switching to a second-generational TKI might not work, but perhaps an earlier trigger might be helpful. In summary, the paper by Marin et al. Made an important contribution that could at least decrease resource utilization and possibly lead to an improved outcome for patients with CML, if an appropriate therapy can be devised for those patients destined to do poorly. Of course, this work will need to be confirmed by other investigators, be applied to a data set in which patients are started on a second-generational tyrosine kinase inhibitor at diagnosis, and then effective alternative therapy will need to be devised. This study represents another milestone in our understanding of how to manage CML patients on tyrosine kinase inhibitors. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.